Hello again, this is Felice D'Arco, and thank you very much for joining again one of the lecture in my YouTube channel that is dedicated to pediatric neuroradiology. Today I'm going to present a lecture called Pre-operative inner ear, what to look for and how to report, which is a lecture that I've done for the European Society of Neuroradiology, in particular for the European course of pediatric neuroradiology that was that took place in Spain, February 2025. And I really invite you to check out the ESNR website. They do a lot of nice courses and conferences, so have a look. What is preoperative inner ear? Basically, keeping it simple, we need to tell the ENT what the ENT needs to know in a clear and effective manner before implanting the cochlea with a cochlear device. And this is very, very important because we need to know where the implant goes. So basically, here you see a drawing where the external transmitter, the receiver when pressed is there, the microphone, but most importantly, this is the electrode. So we need to know where the electrode goes and what are the possible pitfalls by way of pathology or anatomical variant that the surgeon can found having this when planning this operation. Okay, now the first area that the electrode courses is the mastoid. And so we need to tell the ENT about the mastoid, and then it goes into the middle ear and enter the cochlea via round window or cochleostomy sometimes, and then it goes into the cochlea. Now, I'm not going to speak about the post-operative appearances. This will be for another lecture, but it's very, very important that you understand that all these different anatomical location can present some issue for the surgeon. So this is the lecture outline. So first of all, I'm going to tell you which imaging modality is better, or if we need to use both CT, MRI, what about plain film, and so on. And then I'm going to speak about ear malformation, in particular cochlear malformation, with surgical implication. I will put another update lecture on the cochlear malformation, the classification, the implication for genetics, syndromic diagnosis, and so on. But in these specific cases, I just want you to focus on what information, again, the ENT wants to know. And then I will speak about anatomical variants or pathology that can impact the implant. Most importantly, guys, I will try to tell you how I report it in a simple and effective way, in a way that you want an ENT to propose yourself because they will love you. And this is a joke, of course, but it's very, very important. We keep in mind as a radiologist that we are a service and we are communicators, first of all. So it's very important to focus on the important thing, to report them with clarity, and to receive feedback from your surgeons. Now, let's start with the imaging modality. Which one, how, and why? So forget about plain film, at least for the pre-op, you need to use MRI and CT together. So my first pearl, you will see a lot of pearls in this presentation. My first pearl is to use both CT and MRI for preoperative assessment because they are complementary. Now, one exception, I work in a pediatric hospital, and when I spoke with my NT, he said that there are some exceptions. One important exception is that in children, especially small children, we use general anesthesia, we call GA, or sometimes deep sedation. Now, if you have general anesthesia or deep sedation, you don't want to repeat too many times. This is very expensive and also carries some risk for the child. So when we receive a scan, an MRI scan from another hospital of a child for pre-implant, a child who is not syndromic, so we do not expect too many surprises by way of pathological anatomy, and the nerve is there, and we can see on the MRI enough of the cochlea. then we do not repeat the CT and MRI to avoid the GA. So CT and MRI, to summarize, very, very important, both of them. Sometimes in children, MRI can be enough if the child is not syndromic and you already had an MRI under GA done previously, okay? Now, what is the difference between CT and MRI? Well, CT is very, very good for the bone and for the hair. So pneumatization, aeration of the mastoid, middle ear, facial nerve course, and skull-based variant are all visualized on CT. You can see the cochlea, but the cochlea is better on MRI, and I will explain you why in a second. MRI can see the nerves. So because the nerve is a condition sine qua non for the implant, so it's necessary for the implant, then you will need an MRI to visualize the nerve, which is not possible with the CT. And you can see very well the cochlear malformation because an MRI with appropriate sequences will allow you to see very well the internal structure of the cochlea. But also remember there are a lot of associated abnormality in the brain. Sometimes the cause for the hearing loss is in the brain, not in the ear. So you need the MRI to look at the brain. So keep it simple. You need it both, and CT is much better for bone and hair, but cannot visualize the nerve. So second pearl for you guys. So this is why CT and MRI are complementary, just a bit of anatomy. Here you can see very well the internal auditory canals, semicircular canals, the cochlea with the modulus here, the round window, that is the surgical target for inserting the implant, and then the pneumatized mastoids with the ossicles as well. So if there are variants of abnormality in the middle ear, you will be able to pick it up. But you cannot see the nerve. You can see the nerve on MRI. This is the cochleovestibular nerve. You can do parasagittal reformat of the high resolution 3D steady state sequence, and you will visualize the cochlear branch. Remember that you will see vestibular branches on the right hand side, or actually on the posterior lateral side of the internal auditory canal. And then 7 up and cock down. So this is the cochlear branch. This is the target for our pre-surgical evaluation. So approaching, now we know that we need most likely CT and MRI both for our cochlear evaluation. Let's start with the MRI. Look at the MRI and ask yourself, is there the nerve, yes or no? In this case, there is the nerve. You saw it before. In this case, there is no nerve. Also, there is no facial nerve. The important thing is that you will see, and I will come to that later, the cochlea is also malformed and the internal auditory canal is smaller. So you will need the parasagittal reformat or direct acquisition on parasagittal MRI to visualize the nerve, but also the axial is very important. I say also direct acquisition because you know that this is a 3D steady state sequence, like a cyst or a fist. But when we are dealing, especially with malform here, sometimes the internal auditory canal, like in this case, is small or can be very malformed. And remember, although this in theory is a 3D, when you do the reformat, you lose a bit of resolution. And this is why we started to do a Great Ormond Street direct acquisition. You can see how crispier is this, despite you can have important information even with the reformat. But it's very important to realize that the 3D sequences are not perfect as far as the reformats are concerned, and a bit of resolution is always lost. So if you are dealing with a normal cochlea, you are fine, or a normal internal auditory canal, you are fine. But when the internal auditory canal is very, very small, for instance, in charge syndromes and stuff like that, then you really, really, really need as much resolution as possible. And this is a note of color. It's a concept that I learned thanks to Professor Andrea Rossi, who is passionate about the spinal dysraphism. He always teaches about spinal dysraphism. And once in a lecture, he said, you know, if you have a doubt, you need to run a CIS in 2 directions, axial and sagittal, to really, really understand where these abnormal fibers are going into the area of defect. Now, We published this in the guidelines for magnetic resonance imaging pediatric head and neck. There is a section dedicated to cochlear pre-surgical evaluation, so pre-cochlear implant imaging. So please have a look to this paper. But also the axial are very important. These are axial images of the same sequences from my lovely colleague Snia, and focus on the right temporal bone, and you can see the cochlea, but also look at the nerves. So if you start from the cistern part, the cochlear nerve on axial is always double in size than the facial. Why? Because the cochleovestibular nerve is double in size of the facial. So the eighth cranial nerve is double in size of the seven in comparison to the seven nerve on axial, because it has both cochlear and vestibular components. So you can follow this thick nerve in the canal, and then there is the separation between cochlear branch and vestibular branch. So this is very, very important. And you can see the other side, the same cochlear vestibular branches, and then you go back and you see also the seventh nerve that is half of the size of the eighth nerve. But in this case, there is a unilateral abnormality with hypoplastic modulus here and enlargement of the vestibular aqueduct, or rather endolymphatic sac, because we are on MRI. So very, very important that you look also on the axial and you consider the size. Let's continue with the MRI. Is the inner ear malformed or not? So this is very, very important. But for the pre-surgical evaluation, you don't need to use too many terms. You know, we have incomplete partition, type 1, 2, 3, several cochlear hypoplasia, common cavity, rudimentary otocyst, and blah, blah, blah. What is important? First of all, you visualize the nerve. If the nerve is not present, you don't care about the malformation because they cannot implant. Second, you need to ask yourself how the cochlea is different from normal. This is a normal cochlea. There is a modulus, there is a lamina spiralis ossea that divides the scala tympani below, where the electrode will go, and the scala vestibuli above. And then interscalar septa, that are this triangular area of hypointensity here that divides the turns. Now, why this is so important? Because if you have less turns, you have cochlear hypoplasia. If you have abnormalities in this internal structure, you have different degrees of incomplete partition. Why this is important in the preoperative evaluation? Because cochlear hypoplasia, the ENT rather needs to use thinner and shorter electrodes. While if you have abnormal internal structure, some of this incomplete partition may have a risk of CSF leak after the implant. So it's very important. First of all, you can have hypoplasia of the cochlea with some incomplete partition, but it's not, I don't want to go into this level of details at this point, but what is important is that you, first of all, check for the nerve, and second, you decide, is the cochlea hypoplastic or not? And is the cochlea abnormal, incomplete, normal partitioning, so is an incomplete partition cochlea or not? Because if it's hypoplastic, there is a problem for the length and the size of the electrode. And if there is incomplete partitioning, there is a problem. There may be a problem related to CSF leak. Yeah? And also both of them can have displayed facial nerve. So what you do if you decide that the cochlea is short? First check the nerve, then count the turns. You can have some measurement, but they are not extremely effective, especially if the cochlea is malformed. And look at the facial nerve course, and look, of course, at the middle ear on CT. These are three typical examples of cochlear hypoplasia. You see the thick arrow here show a relatively preserved basal turn, or at least the first half of it, but then the upper part is very hypoplastic and tend to be anteriorly displaced, okay? If you have a risk of CSF leak, it's because the internal structure is underdeveloped, and we have three conditions where it is underdeveloped. Incomplete partition type 1, incomplete partition type 3, and common cavity. These are the main conditions that carries a major risk of leaks. The other one, like incomplete partition type 2 or so-called cochlear hypoplasia type 2 or rudimentary otocyst, they don't really have this greater of a risk. And again, look at the facial nerve and the middle ear. So this is the typical appearance of incomplete partition type 3. The internal auditory canal is very large. The interscalar septum is present. So the interscalar septum is again the area of bone that divides the turns, but the rest of the internal structure is missing. So no modulus, no lamina spiralis. The nerves are there, so you can implant, but because of these appearances, you have a high CSF leak. So recognize the IP3. And again, in my other lecture, there will be all the implication about syndromic association and genes, but recognize this. And this is what we call corkscrew appearance, because when you see something like that, you need to call incomplete partition type 3 because like that, and you need to call the ENT and tell them that there will be a risk of CSF leak. If you have an incomplete partition type 1, so a cystic appearance of the cochlea with a cystic appearance of vestibule, this figure of 8, you also have, most of the times, the nerves present. This is facial, this is cochlear vestibular, and this is cochlear and vestibular branches. So the cochlear branch is in red, but you have a risk of Gaucher. So very, very important. And this is the schematic of incomplete partition type 1 versus a normal cochlea, but it's very important that you can have some different development of at least the basis of the modulus, although the cochlea looks like a cyst in different type of incomplete partition type 1, and you can visualize this small residual modulus when present, like in this case in yellow, or when completely absent, like in this case. And of course, in this case, the risk of leak is increased. What about the common cavity? Common cavity is very similar. There is the nerve, but there is basically no clear. These are actually a spectrum, in my opinion, going into each other. But as far as your description is concerned, this is like a separated cyst. This is a common cavity, basically, or fused cyst. But the important thing for you is that there is a nerve, so they can implant, but also there is no internal structure, so you have a CSF leak risk. Finally, labyrinthitis ossificans. Labyrinthitis ossificans is basically so it's an inflammation due to a meningitis that involves the cochlea. And what you need to remember is that there are 3 stages: acute, fibrotic stage, and ossifying stage. And of course, the ossifying stage is the most difficult for the surgeon to intervene on. So this is the acute stage. Is during the acute meningitic process. I missed one of these a few weeks ago because I was so focused on the brain changes and the empyema and the pus and the meningitis that I lost it. And then it came back in the audiology MDT for deafness. So very, very important that you pick it up. But in this case, it's just inflammation. And then it becomes fibrotic, which can be invisible on CT, like in this case, but visible on MRI. So this is a 1.5 Tesla, confirmed on the 3 Tesla, the absence of the normal fluid signal in the lateral semicircular canal. 1 year down the line, and this becomes ossified. So remember, the fibrous stage is less serious and less problematic for the ENT to implant, and this needs to be flagged. That's why I prefer MRI to the CT, because of course you can have, like in this case, the cochlea is completely ossified. And if you do an MRI, you see that the fibrotic stage is much more extensive, involving almost the whole labyrinth. So remember, fibrotic stage is better visualized on MRI. So MRI is more sensitive than CT for labyrinthitis ossificans in this intermediate stage. Remember, another interesting thing that was reported, when you have a complete ossification of the cochlea, like in the case on the left, of the labyrinth, you don't see anything in the otic capsule. So this is the final stage of the labyrinthitis ossificans, but the shape and the size of the otic capsule with the cochlear promontory is still there. If you have complete labyrinthine aplasia, you also don't see anything, but the otic capsule will be very hypoplastic and there will be no cochlear promontory. And this is Lamb syndrome, so this is so-called Michel anomaly. which is another name for complete labyrinthine aplasia. But remember these differences. But of course, the clinical context will be also different because this child was not born deaf, but developed deafness after labyrinthine dissociation. Let's finish with CT. Pneumatization, meaning how many cells are present in the mastoids, and you can have a very aerated mastoid and less aerated mastoid. This is all normal. And by the way, I took this image from Professor Brandstetter presentation on YouTube. It's a great channel dedicated to radiology of the head and neck, so check it out. And you can have several degrees based on the extension of the pneumatization in comparison to the sigmoid sinus. Aeration, meaning that some of the cells are present, but are so under aeration, meaning that the cells are present, but they are filled with fluid. After an inflammation, you can have collapse of some of the cells, so under pneumatization, but also reduction of the aeration. And both cases are not good for the ENT because the ENT doesn't not find easy to go through an ossified atelectasic mastoid, nor wants to go in eye cells that are full of inflammatory debris. So the parallel is that it's much easier for the ENT surgeon to go through pneumatized bone than a solid bone or through inflammatory debris, but also dealing with children, take in account that the pneumatization changes quite faster than the expected pneumatization of the paranasal sinuses. So it's a bit easier for us because after the first year of life, most of the pneumatization is preserved, but still there are publications, look it up, showing the trajectory of pneumatization. What about the eye of the tegment tympani? The eye of the tegment tympani needs to be parallel to a straight line passing to the lateral semicircular canal. This is normal. This is again from Professor Brandstetter. This is not parallel, so this is not normal. Increase the risk of the surgeon to find themselves in the brain. But we are dealing with children, we are dealing often with malformation. Sometimes there is no semicircular canal, like in this case. So again, be descriptive, but describe this abnormal tegment tympani if you have marked inner ear malformation. You can measure again only if you have a normal shape inner ear, and this is a beautiful paper from several co-authors, including my colleague Dr. Biswas. So have a look to this paper. It's very precise, very comprehensive, and they mentioned that the distance between the semicircular canal, the axis passing by the semicircular canal and the tegment tympani needs to be 3.5 millimeters at least. So the depressed tegment tympani, my parallel is, remember there is a risk for the ENT to accidentally find themselves intracranial. What about the vessel? High riding bulb, they can say above the basal canal or, basal turn or above the internal auditory canal, depending on the literature. So have a look and describe accordingly. Think of craniosynostosis if you see a lot of mastoid emissary veins. This was a case of 3MC mutation with a craniosynostosis that was missed, and we had to recall the patient for a full CT brain. And lateralized bulb, there are 3 lines, one passing by the posterior semicircular canal, one passing by the tympanic segment of the facial nerve, and another malleolinguidal axis. So depending on the position of the bulb in comparison to these 3 lines, we have different degrees of lateralization the ENT may want to be aware of. Remember that sometimes you have extra vessels. Most of the vessels you see, extra vessels, are aberrant veins in the otic capsule. Sometimes, like in this case, may be an artery. And it's very important, whether or not you can visualize that or whether or not there are associated abnormalities, that you look, this was visualized also post-contrast, that you look at the skull base. This case, courtesy of Professor Pinelli in Brescia, a great auto radiologist, shows us actually the foramen spinosus that normally is posterolaterally to this structure, that is foramen ovalis, was absent in this case. And that's why this is so important, because if there is no foramen spinosus, you may be 100% sure that there will be a persistent stapedial artery, sometimes in isolation, sometimes associated with an aberrant internal carotid artery. That's very important. This is the same case with hypoplastic spinosus, so can be absent or hypoplastic. But it's very, very important that you look at the rest of the skull base, in particular to the foramen spinosus, because sometimes it's very difficult, especially if you don't have a cone beam CT, to demonstrate a small isolated stapedial artery. And these are the different kind of stapedial artery that you can have. But the most important thing is that it comes off the carotid over the promontory. Sometimes can present as an enlarged seven nerve canal in its tympanic component. The most important thing is that there is no spinosum. And finally, the oval and round window. Round window needs to be present and well aerated. Oval window is this notch without bone connecting the tympanic air with the labyrinth. And sometimes you have a normal situation on one side. This is the oval window. The oval window here is missing, and the seventh nerve is displaced inferiorly. So you don't see the oval window here, you see the seventh nerve. Also, the round window is very small. Sometimes the round window is in fact small, and this is a problem for the ENT that look for the round window to enter the cochlea. So very, very, very important that you look at both of them. If you want a paper on the round window, look at this beautiful review article by some American colleagues. This is another case with normal facial nerve on the left and prolapsing facial nerve on the right. Sometimes in absence of pathologies of the round window. And finally, remember rare anatomical variants. Studying for this presentation, I came across some literature that I had stored in my archive and I forgot about, of course, like the one about the ear fissure. What is the ear fissure? It's this cleft between the aortic capsule here, anteromedially, and the jugular bulb posterolaterally, that create spontaneous or post-procedural otorrhea, but also can create problem in the placement of the electrode, like in these cases. So it's very important that you know your variants in the anatomy. So what are the summary of my pre-cochlear implants checklist? MRI for the nerve, CT for bone and hair. Try to identify if there is a cochlear hypoplasia, so short electrodes or incomplete partition, which carries a risk of CSF leak, and labyrinthitis ossificant for difficult implant that will give you difficulty in implant. But remember, MRI is better because it picks up the intermediate fibrotic stages that is better for the surgeon. Variant to be checked, not only jugular bulb and other main anatomical variants, but rare anatomical variants of the round and oval window that are more pathological kind of than anatomical variants. So this is the end. Thank you so much for staying with me. And if you have any comment, please let me know.